So everybody knows that PPMD's done a fabulous job at creating the Certified Duchenne Care Center program that allows everyone to have access, or at least closer access to care. But if you've ever had an emergency, I think we're all well aware that that emergency is never going to happen in the parking lot of your CDCC. So really important that we know how to recognize these emergencies and how we know how to manage these emergencies. So because the emergencies never happen in the parking lot of the CDCC, Sue's going to speak about how to work with the emergency room and some common emergencies that parents need to be aware of and know how to navigate. Jonathan, as I said, is going to speak about pulmonary. Chet's going to talk about cardiac. And because the parent perspective is so incredibly important, and you all are the ones that are the primary on the front lines of whatever emergency is happening, Ellen's going to speak about the parent perspective. And because I've always wanted to be Oprah, I'm going to sit right here. But I have no cars, so don't get excited.
Sorry, I was up a minute or two late because I was so enthralled with the last speaker. So as Kathy said, I'm Susan Apkon. I'm a pediatric rehabilitation physician at Children's Hospital Colorado. I have the privilege of providing care to not only children, but also adults in our center. As Kathy said, emergencies don't happen, they're unexpected. Right? You don't plan for any emergency. And so I think that hopefully you will take from this session a couple of things. One, be prepared. Ahead of that emergency that you hadn't planned for, have in your mind what you could or should do if that situation arises. A few things just to think about as you are listening to this presentation. When you show up in an emergency department, or before you show up in an emergency department, maybe you were in the home setting, you called 911, you are the expert. You are your own expert if you are someone with Duchenne or Becker muscular dystrophy, or if you are a parent, you are the expert on behalf of your child. I'd like to think that all physicians, all EMTs, all nurses, all people who you will be exposed to in an emergency situation are experts, but the reality is they are not. Duchenne is a rare disease, and so you need to be the one who are comfortable informing others of some of the conditions that we'll be talking about a little bit this morning. Another thing to keep in mind, I'll talk about this in a few minutes, is to remember stress dosing in an emergency situation. When you are on corticosteroids, your body shuts down its own production of corticosteroids. When I am stressed, when I am sick, when I am injured, my body pumps out steroids. If your body has shut it down because you're getting it every day, you aren't able to pump it out. And so therefore, you need to give extra doses of steroids. We understand that not everyone has the ability to be seen in a big academic center where they're generally experts in Duchenne dystrophy. You live in an area that doesn't have a children's hospital, a tertiary or a quaternary care hospital where there are experts in Duchenne or Becker muscular dystrophy. But if you have the ability to go to a center in the setting of an emergency, that's our recommendation. And then finally, prevention is key. Right, we're going to talk about some of the more common emergencies, one being fracture. If you can prevent that fracture by assuring that someone is wearing a seatbelt if they are sitting in a scooter or a wheelchair, that will hopefully prevent that fracture from occurring. I also want to call out that PPMD has done a fabulous job of helping us to remember what to do in an emergency situation. So in your red bags that you received in check-in, there were a number of different items that I think might be helpful. There was the magnet that can be put on a refrigerator. So in case an emergency and EMTs come in, there's a pull-out that has lots of important information like phone calls and medications and special considerations. There was also this card that's been branded Think, and it just helps you to remember to take your equipment. If you are someone on non-invasive ventilation or use a cough assist and you are going in the hospital for respiratory issues, take that equipment with you. Dr. Finder will talk more about that, I'm sure. Hand your emergency card to the team that will be taking care of you. It will list your medical diagnoses. It will mention the medications that you are on, and again, special considerations. Inform about oxygen precautions. Again, Dr. Finder will talk about that, but there are some things that we think about with just giving someone oxygen when they might not need it, or they may need something different than straight oxygen. It's helpful to notify your muscle team in the heat of the moment. That might not be the first thing that you're thinking about, but it's always helpful to let me know that you're coming into the emergency department. Nights and weekends, there's generally someone on call that can help navigate with you and with your care team in the emergency room setting. And that's especially important if you're going to a community hospital that might not have the expertise in Duchenne or Becker muscular dystrophy. And then finally, keep important documents with you. So have that list of medications. If you have advanced directives, have that with you so that your care is provided in the way that you want that care provided. So these are the common emergencies. We have 2 experts, one in heart, one in lung, that are going to talk about that. I'm going to talk about bones, and I'm going to talk about GI issues or abdominal issues. Fractures. I mentioned the seatbelt. One of the most common reasons that a child has a fracture is falling out of a wheelchair. When I see the child in clinic and I ask about the situation, it's generally related to the fact that the child didn't have a seatbelt on. Going up or down an incline, boys are boys, and they may be roughhousing out in the, outside and going up over uneven surfaces. If you don't have your seatbelt on, things tip. Then you end up with a fracture. The most common site of a fracture is the distal femur. So this picture here, this is the femur bone, the thigh bone right here, and the distal part, that's the top right above the knee, is the most common place for a fracture to occur. One thing that's important to note is we're not talking about big-time trauma in some situations, right? So it's not a kid that's climbing a tree and then falls 10 feet out of the tree who fractures their bone. We're talking about sometimes going through a doorway in a wheelchair and the leg just gets caught in a funny way, transfers. Sometimes stretching has led to fractures. So when you have Duchenne, whether you're on steroids or not, steroids make it worse, but whether you're on steroids or not, you have decreased bone mineral density. Your bones are like bones of a little old lady. These are kids who haven't run and jumped through life to accrue bone density. You add steroids on top of it again. So the fact that you don't have to come into the hospital and say, my kid fell out of a tree, I think they have a fracture. It might be, I think they have a fracture, they just went through a doorway. They seem to be uncomfortable, they have a little bit of swelling. And an x-ray at that point is obviously indicated. I want to mention vertebral fractures. Those are fractures in the spine, and those can occur with going over a bumpy surface. I've had kids present that way, or fall. And that's usually related to kids who have been on chronic steroids, less likely for kids who have not been on steroids. So if you are in the emergency department and your child has a fracture of their leg and their child is still ambulatory, we encourage you to have a conversation with your surgeon, the orthopedic surgeon, pull in your muscle team. But if it's possible to do a surgery to fixate that, to strengthen that, to put a rod through it, that's generally the recommendation because the goal is to get those kids back up on their feet. Now, depending on the type of fracture, it may not be necessary to actually put a rod in. It might be in a location that just doesn't make sense. But that's something to think about. I always worry that a child comes in a wheelchair, although still walking, that orthopedic surgeon unconsciously is thinking we just have to provide that support and not necessarily a surgery. And so, again, you as your child's expert or you as an expert should be advocating for that. If you are not ambulatory and the fracture is stable, then oftentimes we just put a big padded splint on. We don't even cast it. That cast is heavy, can lead to other issues. A big padded splint is oftentimes all that's needed. We want to make sure kids are comfortable. So pain medication is okay in reasonable doses. Narcotics, oxycodone, things like that are fine in the setting of short-term and in appropriate doses. So if your child is uncomfortable, make sure that they're getting good pain relief. I put in big, bold letters, fat embolized syndrome. That's something that is in all of the PPMD literature. It is an entity I'll talk about in a second. It's real, it exists, but people in the emergency department don't always think about it because it's not common. It's common in our guys, but it's not common necessarily in general population. I mentioned stress doses again. So if your child is going to go into surgery to fix that femur fracture, a couple of things. One, as you know, anesthesia can be risky in a child with Duchenne or Becker muscular dystrophy. They can develop a complication related to muscle breakdown and elevated levels of potassium that can be quite concerning. So we talk about not using inhaled anesthesia. We talk about succinylcholine, which is one of those anesthesias that is contraindicated in the setting of Duchenne or Becker. So that's something that is in that emergency card. Most anesthesiologists will know this. It is sort of their biggest fear that they're going to cause this potential complication. But reiterating that is always a good thing. The other thing is if your child's going under anesthesia and they are on BiPAP, or use a cough assist, making sure that you have that so that when they are extubated, meaning the breathing tube comes out, then that mask, their BiPAP mask goes on, and they are getting good ventilation. Again, I'm guessing that Dr. Finder will talk a little bit about that. And finally, if your child's not been seen by a cardiologist in quite some time before they go under anesthesia, it's important to make sure that cardiology is involved. And at least a call to the cardiologist on your muscle team will be helpful to know whether or not a repeat EKG or echo is indicated before the child goes under anesthesia. So fat embolized syndrome, FES, you'll hear about. It's rare, but it's serious. And it's followed typically long bone fractures. There's been reports of it just with heavy trauma and not even a fracture. So generally, there's fat in our bone marrow. And there may be more fat in bone marrow of someone who's on corticosteroids. There's a fracture, that fat gets released, goes into the bloodstream, and it causes havoc. What I will say is if you go into the emergency department, you talk to a provider in the emergency department, and you mention fat embolized syndrome, they'll say, we don't have to worry about it. It usually occurs a couple of days after a fracture. That has not been my experience. In almost every case of fat embolized syndrome, kids are coming into the emergency department with symptoms already. And the symptoms include breathing, so respiratory distress. It's not a pneumonia, right? It's not a little viral illness. It is, in the setting of a fracture, it is fat embolized syndrome until proven otherwise. You can have brain involvement, so you can have just confusion, goofiness. You could have decreased level of consciousness. You could have seizures. Again, these are things that occur more immediately. And finally, you can have skin changes. We call it petechiae. Those are red dots that when you touch them, they don't go away. We say they're non-blanching. That is one thing that does typically occur a little bit later, a couple of days in. So it's the breathing and it's the cognitive manifestations of fat embolized syndrome that we think about immediately. And treatment is early recognition. Going back to the idea of you are your child's expert, or you are an expert if you have Duchenne or Becker. So recognizing the signs and symptoms, advocating on behalf of your child. If you're in the home setting and you're not quite sure that there's a fracture and the kid's uncomfortable, and then you start seeing respiratory issues or confusion, that is a 911 call because of the need for treatment. And finally, I already said it, alerting the emergency room providers to this possibility. So in general, we stabilize the fracture. So it doesn't necessarily mean going right to surgery, but it's stabilizing again with a well-padded splint that doesn't allow that bone to move. It's supportive care. There isn't a medication really that treats fat embolized syndrome. It's really supportive care. So supporting the respiratory system, usually getting a kid on their BiPAP, if they're not on BiPAP normally, maybe instituting BiPAP or oxygen, It's supporting their cardiac function, hydrating them well. Sometimes you're going to have a drop in platelets and you might need a transfusion. And then again, stress doses of steroids are indicated in this situation. Now quickly go over a couple other things. Abdominal pain. Lots of people have abdominal pain in the setting of Duchenne or Becker. It may be related to something like constipation. Again, a very typical childhood issue when you're a little bit less mobile, maybe not wanting to drink a lot because you don't want to then have to pee. We do see constipation a little bit more commonly. Gastritis associated with steroid use, so vomiting, blood, or having stool that is dark, tarry-like is an indicator of that. Appendicitis, right? Kids have typical kid issues. Right lower quadrant pain could be appendicitis. And then kidney stones, something that we do see may be related to the decreased bone mineral density issues, the steroid issues, the decrease in water issues, and so kidney stones are something else. The one thing that I did put at the very bottom of the slide, something to remember. So if your child goes into the hospital and they are just looking sick or feeling sick, they may get blood work. And oftentimes in the emergency room setting, they'll just sort of just screen sort of with general labs. So they'll do a blood count, and they'll usually do something like liver function tests. And all of a sudden, like, you know, everyone comes running because the ALT or the AST, we also say SGOT, SGPT, are super high, and everyone says, I got it, I know what this is hepatitis. This is a liver issue. But all of you know, in the setting of Duchenne, that high liver function tests actually are just something that we see. They are not specific, so that ALT and the AST are not specific to liver. They actually are also specific to muscle. And so someone with a muscular dystrophy of any sort will have increased levels of that. It has nothing to do with the liver at all. The liver is healthy as long as you advocate on behalf of your son or yourself and have them check a very specific liver test, which is a GGT, and it will be normal. They can sort of say, all right, it's not hepatitis, it's something else. And then finally, steroids and emergencies. So a couple of key points. Never stop your steroids abruptly. Remember I said your body gets used to it. You've been taking it every day or on weekends for years, and so your own system has shut down. Your adrenal glands have sort of went into sleep mode. When you are stressed, you need those steroids. And so stopping it abruptly is not something that would make kids or adults feel well. If you can't take it by mouth because you're puking or you're going into anesthesia, so you are NPO, then you need IV steroids, and then extra doses of steroids when you're stressed. So your baseline steroids might then increase. PPMD has done a fabulous job with putting all of this on the website and would refer you to that. And finally, this is also something that PPMD has done just a wonderful job. They've always done a wonderful job, but recently sort of have relooked at the emergency room guidelines, and so this is something that was in your red bags, and I would encourage you to use that. So I will end there and hand it off, I guess, to the next speaker. That
would be great.
All right.
Thank you, Sue. So as Sue's transitioning, I will just say that PPMD has an emergency app, and if any of you do not, you are.
Okay.
I think.
Unfortunately, our slides overlap.
If you do not have the emergency app on your phone, please don't leave this conference without downloading it. If you need any help with that, let us know. And the PJ Nikolov steroid protocol is part of that app, so make sure you have that. All right, now it's your turn.
All right, thanks, folks. A real privilege to be here, my 24th year in a row, being part of this event, 2 of them virtually. So I'm going to talk about respiratory emergencies in muscular dystrophy. There are only 3, and we actually had some overlap in our slides, so I'll probably go quickly through some of them. There are really only 3 that we're going to talk about. Pneumonia, which is a very common thing, and we're certainly going to see that, lots of that. Respiratory failure, unfortunately, is also fairly common in the older patients. We'll talk about that. And we'll probably skip a little bit over my slides on FES because we've certainly seen cases here, and certainly it's recognition that's the most important thing for that, rather than treatment so much as the supportive care for that. Pneumonia is a common thing. We all get pneumonia. It's out there. Certainly COVID is a form of pneumonia. Typically you get fever with that, but occasionally you can have pneumonia without fever. The chest x-ray should be positive, and so when you emergency room, you should go and ask for a chest x-ray if you're worried about pneumonia. But it's something important to point out, which is that it is very, very common to have an area of volume loss, and the word we use is called atelectasis. That's kind of a funny medical term meaning essentially that there's a loss of the volume within a portion of a lung. And that word atelectatic lung or atelectasis means that there is some area of collapse within the lung. It is not a, quote, collapsed lung. It's just an area within the lung where a portion of the lung has deflated. It is very common to see the left lower lobe deflated in Duchenne. Why is that? Because the heart gets large and it can compress the left lower lobe bronchus. And so if you get a little bit of mucus in there, you have a weak cough, you got compression, all these factors lead to chronic compression, and it's very common to have a chronic volume loss in the left lower lobe, and that is not pneumonia. Almost always the emergency room doc will see this x-ray and go, oh, he's got left lower lobe pneumonia. I want you all to remember that the left lower lobe quite often is abnormal in the older patients, say 15 and above. So it's really helpful to have seen and know what your son's baseline chest x-ray looks like. So if someone has a weak cough, the answer is you've got to give a cough assist. You've got to use a cough assist, and if you haven't had one before, you might need one. It might be that we've worked hard to avoid people showing up with pneumonia by getting them cough assist before they need it, but sometimes we still see this, and the cough assist device should be in most hospitals, but unfortunately they're not in every hospital. Do not accept or ask for a cough suppressant. We do not want to suppress the cough in pneumonia. We want to encourage coughing, we want to help coughing. But a cough suppressant is a way of keeping pneumonia in place. You got to clear those airways. So encouraging coughing, using the cough assist device aggressively. And I can talk to you about how to set up. If you have questions about how to set up your cough assist device, talk to me. I've been using the cough assist device since 1994. I know a lot about it. I'm happy to talk to you. Without assisted coughing, you are not going to resolve the pneumonia. You've got to clear the airways. It's not enough just to give antibiotics. Shifting to respiratory failure, it's unfortunately very common. And the way you define respiratory failure in this disease is you've got to get a carbon dioxide level. Now, that can be an exhaled carbon dioxide level. That's painless, and it's great, and it's a very sensitive test. And if someone's carbon dioxide level is high, and by high we choose a number of 45 and above is considered high. But you can also get a venous gas or an arterial or capillary gas. There's lots of ways of getting the sample. You've got to get a CO2 level. And the biggest mistake I see made in emergency rooms is they get some kid who shows up and he has a left lower lobe collapse, atelectasis, because that's his baseline. And they go, oh, you got pneumonia. And your saturation is low because your carbon dioxide level is high. So as the carbon dioxide level rises, the oxygen level falls. And so they would give you oxygen, which is obviously a problem. And so one of the clues to a person in respiratory failure is they're not speaking in very long sentences. They are speaking in very short sentences, and they can't really have a full sentence. And so that's a real clue that something is not right with the ability to breathe. Early on, you'll have respiratory failure in sleep. Later on, you'll have respiratory failure during the awake time. And this is where we know you've got a card in your red bags that says do not just give oxygen. You've got to know the person's carbon dioxide level. Why is that? Because oxygen will suppress the body's drive. So we have what's called a drive. We have two forms of drive. One is you sense carbon dioxide levels inside the brain, and if you have a high carbon dioxide level for a long time, the body gets used to that. So then the primary driver of breathing becomes the oxygen level. And if you suppress oxygen by giving extra oxygen, then that can actually put you into acute respiratory failure, and we do not want to have that happen. So oxygen can be hazardous to your health. And so I tell everybody to avoid oxygen. It'll precipitate respiratory failure. So a low saturation on if you measure the pulse oximeter, and you can buy a pulse oximeter at Walgreens for, you know, 25 bucks or whatever the number is, or go on Amazon. There's lots of them out there now. Low saturation doesn't just mean you need oxygen. It means you need to check the carbon dioxide level. And so if someone is trying to give your kid oxygen, you make sure that they have checked your carbon dioxide level. Always, always check the CO2, whether it's exhaled carbon dioxide or a blood carbon dioxide level. You make sure that someone's checking that, because this is a common dropped ball. I've seen it in my own hospital, and I give talks. Now, FEF, we've talked a bit about this, and unfortunately, we didn't have good coordination today. I apologize for that. It should generally follow a long bone fracture, and we talked about how fat can move into the heart and into the lungs. It's generally presenting about a day after the event. Low oxygen levels are common, and we talked about the rash. And here's something that the previous speaker didn't talk about, which is a great trick. If you're ever worried about this, the most non-invasive test of all is just to ask an ophthalmologist to look into your child's eyes. You can see the globules of fat in the retina. And so I've actually made a diagnosis over the telephone with one of our members here, where I said, look, your kid was in the ICU and was in respiratory failure, and I said, get an ophthalmology consult. And boom, that was your diagnosis. And I love the fact that you can make a diagnosis without fancy x-rays or CAT scans or anything, just have someone look into your eyes. So that's a great thing to remember, is to get an ophthalmology consult. Because usually the x-rays are normal, again, supportive treatment, and most of the time the recovery is spontaneous within days. And it's important to bear in mind that we at PPMD, and I say we, I was on the board for 6 years, so I still feel like I'm part of PPMD, we have your back. You as parents will know more about this disease than the doc in the emergency room. Some random doc in a community hospital, you will know a lot more. But don't be afraid to reach out. I can't tell you how many times over the past 20 plus years I've had phone calls from people, and I've spoken to physicians. I'm happy to do it. I know, and Kathy for many years will attest that that I'm one of the people on her speed dial. This PPMD has a whole host of folks that are happy to help you and help your docs. And so I've talked to docs all over the country and all over the world. I've talked to people in Pakistan and Africa. Happy to help any way we can. Whenever expertise we can lend, we are happy to give that to you. And so PPMD has your back, and don't forget about using PPMD as a resource. And don't have a problem pressuring the random ER doc at 2 o'clock in the morning to say, I need you to call so-and-so. I'm not crazy about 2 o'clock in the morning personally, but I'm happy to help. I consider it a great privilege to be able to help, and I've really been honored to be part of this organization. So that's all my slides. Thank you so much.
Thank you, Jonathan. Chet? Clicker. It is important to remember that you're not alone out there, so don't be afraid to reach out.
So thank you again. I think this is really fundamental that we have multiple people up here. What has improved outcomes over the long term is not a single cardiologist, it's not a pulmonologist, it's not a neurologist, it's actually everyone working together, right? Your son or daughter is not defined by their dystrophinopathy, and they're not defined by one organ system. It's not just the heart, it's not just the lungs. And to do this efficiently and effectively, you have to mobilize a team and take that whole picture into consideration. And so when I think about emergency care planning, while everyone thinks about the end point, I think actually to do it efficiently, effectively, you have to actually prepare for it. And from a cardiac perspective, that starts with knowing your testing. You heard it from Dr. Apkon. But if I don't know what your baseline is, it's really hard for me to understand what's going on. Has something changed, right? Each child in here is different, right? Their hair color is different, their eye color is different. It turns out their cardiac testing is all different. There are some generalities that I have, but if I don't know what things have been in the last 6 to 12 months, a one-time test is really hard for me to figure out what's going on. After a couple of tests or a couple of days, I might be able to do that. But oftentimes in an emergency, we need to know right now to get timely and effective care. 2, activating an individualized care plan. There are some generalities here, but again, your son or daughter is their own person. There are going to be some important differences to keep in mind, even if 80 to 90% of this is going to be applicable across the board. 3, encouraging communication. You just heard it. I think this is really important. We spend all of our time thinking about this and doing this, and yet most of the time it doesn't happen right in the, in the parking lot of Cincinnati Children's. You go out, you live your lives, you travel, you go on vacations, things happen, and you have to have a way to communicate. And then 4, the last part, timely diagnosis and care. That's the end point, but everything else leads up to that. And why this matters is it turns out, even for somebody who thinks about this and does this all day, diagnosing heart failure is really hard in patients with neuromuscular disease, and especially Duchenne. As you heard, the liver labs can be abnormal independent of anything else going on. The kidney labs also can be that way. And then things like swelling of the feet, shortness of breath, cough, nausea, vomiting, you heard all of that. That can happen independent of anything else. But those can also be symptoms of heart failure. And I use that nausea and vomiting as an example. We've had a couple of men who ended up needing advanced support, and they came in with nausea and vomiting, and people didn't quite figure out. They said, well, you're on steroids, you have all these other things, and they didn't quite realize that was one of the manifestations of heart failure, especially when you're non-ambulatory, right? For any of us, we have what's called the New York Heart Classification. How many steps can you walk up? When do you feel short of breath? All of that sort of stuff. It turns out that is not based or developed for somebody who is non-ambulatory. And you have to keep this in the back of your mind, especially for older men, and that's where that testing is important. I know where your function has been. That gives me an idea of how some of these symptoms may show up and may be a little bit different. And the other part, right, the heart and lung, they live in the same neighborhood, and it turns out I refer to them as frenemies. You may try and treat one, and then it's whack-a-mole. Right? You treat the lung by saying somebody is having respiratory failure, they need to be intubated. Well, it turns out that pressure and that extra ventilation can sometimes cause untoward side effects in the heart, or if you're treating the heart, vice versa can happen. And it's a very fluid situation. This is where that communication and knowing your team is very important, right? Because sometimes they even have to have a conversation on the back end to be able to try and make sense of this. Because as a cardiologist, I can't do my job without a pulmonologist, especially for men or for teenagers who have more advanced disease. Or if they have both heart and lung problems and weakness at baseline, it can be very, very challenging to figure out. So what is your baseline? So getting routine care is the first step in actually preparing for these. Your echo and your MRI, I need to know where that is to begin with. Same thing from an EKG perspective. We have had men who have gone into an adult emergency room, they see that EKG, they do not know that that can be abnormal in Duchenne, and they actually take them off to look at their coronaries because they're worried they're having a heart attack. Because they see that area of scar on the EKG and they go, you're having a heart attack, and they have no idea that that can happen and does happen in 90 to 95% of the men that we take care of by the time they get to their 20s. Heart rate and blood pressure. As you've heard from a couple of speakers along the way, the heart rate is going to be elevated in men with Duchenne no matter what. Even if I have them on the highest dose of the medications that we use, the nerves that actually go into the heart are affected. So just like you've heard people say, Duchenne affects the brain, well, it turns out those nerves that come from the brain go down and tell the heart how fast to go, and it's going to be a little bit elevated. So you have to be able to keep that into perspective. So is it high for your son, or is it just the same, right? If they're usually 90 and they're 90, that gives us an idea of how sick your child may be. Same thing from a blood pressure perspective. The older men that I take care of, 95% of them have a blood pressure. The top number, the systolic blood pressure, is in the 90s on a good day. If you come into an emergency room that is not used to doing that, they're going to start losing their mind, and they're going to start over-treating you. They're going to give you fluid. If your heart's not perfect, then that's going to back up into the lungs, and then we end up in this cycle. We do have to be timely with our therapies, but we also have to avoid things, just like oxygen, that can actually set us into a spiral that's different for boys or men with neuromuscular disease. And then the last thing, those labs. Again, if they're looking at it like they want to compare it to somebody who doesn't have neuromuscular disease, they're going to lose their mind. Know where your baseline is or have access to it so that you can help kind of put the team in the right place. Having a written plan. I use the example of me going to the grocery store. When I was in medical school, my mom came with me to go to the grocery store. We get in the car, I'm ready to go, and she looks over at me and she says, "Where's your list?" And I don't need a list. I'm a doctor, I'm important. I can find my way around the grocery store. And I proceeded to flit around, forget things, go back. Oh, I forgot the bread. I got to go back and get yogurt. All those sorts of things, and that's in a grocery store. This may be the most stressful moment in your life. And you're going to try and remember all of those things. It is asking too much of yourself. Have it written down. That's where the think comes into play, right? Have those ways to help remind, what do I need to do? And again, at the end of that, my mom looks over at me when we're on our way home and she goes, "Next time I'll write the list." And I think that is so important, right? Even for somebody who takes care of acute stuff all the time, your brain is not going to be where you want it to be. And God forbid something happens, you'll be thinking, "Oh my gosh, I forgot this or that." Have a list, right? We do it for sillier things. We do it for going to the grocery store. Be prepared for this. And coming back to that kind of multidisciplinary care, what I say is mobilize to stabilize. No matter what the issue is, what we need to do is get you timely therapy so that we can fix whatever problem it is. Whether it's constipation, whether it's appendicitis, we need to make sure the heart and lungs and the steroid plan are initiated early and dealt with so that way you can deal with the other stuff and so we don't start to complicate the issue. So again, phone numbers. From my perspective, we have our phone numbers on all of our discharge stuff. When I started at Cincinnati Children's, the phone tree was usually one person. I used GI. I was on service last week. When I started, there was one person to call. Really simple. When I looked last week, when I was trying to figure out who to call for somebody who's been there 20 years, there are now 10 people on there. Do I want the one fellow or the other fellow? Do I want the attending who's taking outpatient? Because I'm not really inpatient. Wait, there's a liver doctor, there's another one, and it turns out that happens for every subspecialty. And if it's an emergency, you want to know where to go and not talk to the random person who's trying to set the phone calls in the right spot. Know your numbers for your team, and it's your whole muscle team, right? Because I actually want to know all the time from a heart perspective, even if I can say, "Nope, you're fine." I always would rather know than not know, and then try to figure out things afterwards. Steroids, you heard Kathy talk about the Oprah approach, everyone gets a car. Well, my answer is, from a steroid perspective, everyone gets steroids. I have never once regretted giving steroids. There are multiple people that I've taken care of where I regret that they did not get it. Full stop. If you're wondering, should I give it? The answer is yes. The moment that even creeps into your head, yes. And then lastly, person-specific consideration, heart, lung, other. There are going to be some things that are different about you that it's important to convey to others. And so that last part, that timely diagnosis and care, this is also, from a last perspective on a cardiac thing, I have such a low threshold for re-imaging somebody or getting an EKG or other stuff, even if I think I know what's going on, especially in men with more advanced heart and lung stuff, because it sometimes can be very challenging to tell. Whether that area of atelectasis is actually because fluid has been building up because the heart is doing worse. And you will only regret, I think, in this situation, especially if you have a team that can help people go through that testing, not getting it. So I've given up on the idea that I know what's going on. Get more testing, especially non-invasive testing, and then we can help you get through it.
Thanks, Chet. So as a first responder and an expert, and the person who's the most important in the ER, Ellen's going to talk about the parent perspective.
So hello, everyone, and we've heard some great information from these wonderful physicians, but at the end of the day, they're not there when it's midnight and your kid has 104 fever and you don't know what to do. And so those of us in the audience who have been there all know the feeling, and I'll just share a little bit of my experience. My son Tim isn't here anymore. He passed away about 4 years ago. He was 19, but I've been in the space for a long time and have had many opportunities to deal with emergencies, unfortunately. So one of the stories I like to tell is Tim was about 17 or 18, and we had gone out to lunch. Oh, we had gone to an academic meeting, which is like, I don't know, like a decathlon where they compete with academic questions, and it really is like watching paint dry. It's one of the worst experiences you could ever have. So I sat there and listened to these really geeky kids that knew answers to things I never knew I wanted to know. We went out to lunch, and he started to choke, and he always had a problem swallowing. We were very used to it. It was a piece of bread. He couldn't really get it up. And I don't mean choking like he's not getting air in his airway, just like coughing and he can't cough up what's stuck. So we walk out of the restaurant, he continues to cough. I have known in the past if you move his position in the wheelchair, sometimes that's enough to just move it around and he can clear it. Still couldn't get it up. So now we're getting into like 45 minutes and he's getting tired. And that's when things start to get scary, right? He's fatigued, he can't get it up, I'm starting to get concerned. Well, I can't put him in the car, in the van, because I can't do anything if I'm driving and he's in the back of the van. So I'm sitting in this parking lot like 30 minutes from home, and I thought, all right, I have to call 911. It's never anybody's first choice. It's scary, but what am I going to do? So I call 911. The ambulance guys are great. They do the same thing as me. They pick him up and move him around in his chair. It doesn't work. So we got him in the ambulance. I get his chair in the van. I follow them to the hospital. I walk into the, first they didn't want to let me in the ER. They're like, well, you know, maybe he was 18. You know, he's 18, you don't need to be in there. I'm like, your staff wants me in there because I know far more than they know. Well, you know, this woman in the admitting or whoever she is looking at me like, you are not a physician, are you? I said, no, but I've been dealing with DMD for a long time, and I'm going to be willing to bet that there's nobody on your staff in the ER right now that has dealt with DMD. So she calls back, and they're like, oh, yeah, we want the mom. So I finally get in, and he is in a knockdown, drag-out fight with this nurse nurse practitioner who's telling him he needs oxygen. And he is telling her, I do not need oxygen. You need to wait for my mom. My dad is going to get my cough machine. I called my husband and said, you need to go home and get the cough machine. I don't have one with me. So my husband's on his way with the cough machine, and Tim's oxygen level is low. And this nurse practitioner is insisting on oxygen. And finally he says to her, are you really trying to kill me? I do not want oxygen. You're going to kill me. And he's getting really upset. So I intervene and I explain why he doesn't need oxygen, because I've heard Dr. Finder explain it many times. And I say, but what he does need is a BiPAP. Can you call respiratory and bring a BiPAP down? He's really getting tired. If we give him some time on the BiPAP while we wait for the cough assist, he's going to be fine. We've done this a million times. So that takes about 20 minutes. They finally agree to call respiratory. They bring him the BiPAP. He starts to look better as soon as he gets on the BiPAP. Then this nurse practitioner comes back in the room again and she says, well, we need to do a series of x-rays. He sounds terrible. I said, he doesn't need a chest x-ray. Just give me 15 minutes, use the cough assist. So finally, the cough assist gets there. 3 attempts on the cough assist, we clear him, he's perfectly fine. His chest is clear and he wants to go home. I said, well, you know, let's just sit here 10 more minutes and give a little more time on the BiPAP. So finally the attending comes in the room and he says to me, and this was the most insulting part of the whole day, don't worry, I wasn't gonna let that nurse kill your son. Are you freaking kidding me? Then where were you in the last hour that I am fighting with this person who does not know anything about what I know? And then he says to me, I need to look at this cough assist. I've never seen one before, and we don't have one. This is a level 1 trauma center, not obviously a pediatric hospital or CDC, but a level 1 trauma center. And he looks at it, and he asks respiratory about it, and he picks it up, and he asks me how it works, and he says, I'm writing a purchase order now. This will never happen again. We will have a cough assist, and we will understand how to use it. And I appreciate you telling me how this works. So that's kind of a long story to get at that really you are the expert, and you need to be confident in that, and confident in understanding not just what these physicians talked about today, because it is impossible to remember all of it in the moment of terror, but make sure you have an emergency card filled out. Make sure you know who your physicians are. Make sure you look at Think and you bring your equipment with you. So what I did on Monday after that little episode is I got a portable cough machine. The original cough machines were, you know, like this big, and they weren't very easy to take with you. And insurance actually didn't want to replace it. But after they got the bill for the ER and the ambulance, suddenly it was okay to have a portable cough assist. Sometimes that's how it works. Another piece of advice from a previous experience in the ER, and actually this was an experience at the Children's Hospital, is sometimes it's really difficult to work with residents. Sometimes you really have to insist that you see the attending. Residents have something to prove, and so they're even less likely, and this is only my anecdotal experience, I don't have any research on this, but they're much less likely in my experience and many of my Duchenne friends' experience to give parents the time of day. They're looking to be important, they're looking to set their mark on the world, they don't want to listen to their mom and bring a grocery list, and they don't want to listen to this mom who's telling them about medical advice. So sometimes you really have to insist on saying, I understand your perspective, but this is very serious and I need to see the attending. And I have found the attending is much more willing to understand what the parents have to say. They've had a lot more experience and they're much more comfortable understanding the parents know more in an emergency about a rare disease. And this is a rare disease. It doesn't always seem like it to us. We're in a room with all these people that share the rare disease. We live in this rare disease world. But the reality is, when you get out of our little Duchenne world, this is a rare disease. So there's many people you're going to encounter who have not seen it before and certainly don't have the background. And then again, I can't emphasize enough how important it is to call your neuromuscular team. Another time we were in the hospital for another issue, because really we had a few experiences. And they wanted to call the neurologist. And I said, well, he's on a plane. And they're like, how do you know where your neurologist is on Friday afternoon? I'm like, it's World Muscle this week. They're all going to World Muscle. And they said to me, they can't all be going. I said, you can call, but they're all going to World Muscle. And he comes back, he's like, sometimes I just can't understand how people know what they know. But you're right, I was told he's on his way to World Muscle. And it was actually Dr. Flanagan, and they did get a message to him. And when he landed, he did call back immediately, and everything was fine in that instance. But you offer that information. Don't forget about steroids. PJ's protocol is great. Brian Nikoloff has been really good to the community. Brian lost his son to Duchenne, and it's been really Brian's life work to make sure that nobody else is in the situation where they don't get a steroid stress dose when they need it. So it's really an important thing to think about. I just can't say enough, be ready for the emergency. When Tim was here, we had an envelope in every car because this is going back. Now you can just use your phone. And in that envelope was all the information you might need in an emergency. So that all you had to do is take the envelope out of the glove box when you went into the hospital or wherever you were. But now it's so much easier. It's a QR code on your phone, and like life is just better with cell phones. So anyway, thank you all, and I'm happy to answer any questions anyone might have.
So we have time for just a few questions. If anybody has anything burning, please go to the mic. Is there a virtual question, Brian?
Yeah, so let me start first with a comment. Most families, or many families, travel for interdisciplinary care because they want their sons to be seen by more experienced Duchenne physicians. And one of the things that I have always advocated is that they also maintain a team at home who are familiar with their son. Because during an emergency, it's inappropriate, it's dangerous to travel. You don't have time to board a plane, fly 4 hours to clinic when your son is in some sort of distress. The first question that I have is regards to fat embolized syndrome, and there are multiple different protocols for steroid therapy. And the question has come in regarding weekend dosing and how do we do stress dosing with that. There's also a question regarding AST and ALT levels being high, but there's a question regarding whether there's an answer why ALP would be low in Duchenne, and they've ruled out hypophosphatasia, forgive the pronunciation. The level is 90 and there's no answer why. So there's a couple just to get started with.
Okay. Sue, do you want to talk about the possible pros and cons of stress dosing on weekends or stress dosing in general?
Yeah, so generally if you're on weekend, first of all, the protocol on the PPMD website has this all written out, and so I would refer people to that. But in brief, if you're on weekend dosing, you still need stress doses on a daily basis. And so we just revert you to a dose during the weekdays in the setting of an emergency, a surgery, vomiting, something like that.
So I think, as Chet said, it's more dangerous to not give it when needed than to give it when it maybe is not needed. So it's always a good idea to give it.
And I think the other thing, the natural variation in how our bodies make those steroids tends to wane at night. So just like for whatever reason, emergencies don't happen in the middle of the day, it turns out when you're in the ER, it tends to be in the middle of the night. And that's when your body usually is trying to shut itself down, go to bed, make your heart rate go down, make your blood pressure go down. And it turns out those are things you don't want in an emergency. So it makes it even more likely that you're going to need that just from your body's natural variation through that time. So again, I'm not kidding. Oprah, just give it. Just give it. You will not regret it in the morning. 1 or 2 doses, even to get you through the night while your team is trying to make sense of what is going on. You do not want to regret, and because you can't get it back. And oftentimes, this is where the heart and lung stuff matters, because usually the first answer when your blood pressure is low, when you're in a hospital, is give fluid. Give fluid, give fluid, give fluid to try and tank back up the system, and that can sometimes have devastating consequences if your heart or lungs are not in a good place.
One comment I'll make, many health records, now electronic health records, have the ability to have alerts. And so when I open the chart of a patient I see in our clinic who's on steroids, immediately the first thing I see is that the child's on steroids and needs stress doses if they are sick. And so you may want to ask your providers whether or not that is an option for you or for your child. But it's inherent. We use Epic at Children's Hospital Colorado, and it's the Epic system alerts me immediately as soon as I open a chart. So I'd encourage people to think about that and leverage the capabilities of the electronic medical records.
Can I ask a question about that? So in regards to Brian's comment about getting care in a local hospital, it's my understanding, and correct me if I'm wrong, that if you have an Epic record in Cincinnati or in Children's in Colorado, and I'm home in McHenry, Illinois, and my hospital is also on Epic, when they go in, they can pull my son's record up and see that alert. Is that true?
That may not be true.
I don't think so.
Yeah,
Not the alert.
I think that alert system is unique to our hospital, and we program it. His records may be available in terms of pulling it up. It's called Care Everywhere. And so the records to the providers in your local community may be available, but some of the things that we put in, the nuances, the alerts, I don't believe are available.
EMRs don't talk to each other very well. Epic is maybe the most commonly used one, but if you're on Cerner, Cerner doesn't talk very well to Epic, and if you're using something else, the likelihood of it is a small community hospital may not be on Epic, unfortunately.
And the other thing to keep in mind is in an emergency, right? So you come to these clinics, and if you go to one interdisciplinary clinic, you can have anywhere between 6 and 8 notes written in that time. And in an emergency, they're going to be trying to sort through all that information. And if you've ever seen one of our clinic notes, it is a holy disaster. Half of it's there just for billing, trying to make sense of what's what and distill it. That's why having it in a short and accessible place matters, because trying to get through the medical record when most of it is built for billing, not actually for patient care, it's not what you want in an emergency.
All right, David, we have time for
just
one
a quick question.
and then we're going to have to
Bike
wrap.
riders, we use something called Road ID, which allows an emergency provider to go onto your bracelet and immediately go online to get access to all these records. What do we have for the kids, particularly younger ones, as far as what they could have as a bracelet or something in their sneakers or something like that to give that data?
Yeah, there's some cool options for medical alert bracelets. I typically recommend our kids have medical alert bracelets. They can be ankle bands, there could be wristbands, there could be necklaces. They're cool. There's whatever design you're looking for. Sports teams, animals, whatever are available, and embedded in that is is either a link, a URL code, a number, a chip, whatever it is. So I think it's a brilliant comment that you made, and would encourage people to have that.
So I apologize that we need to stop. I'm so sorry. Sorry, Gloria. But we need to move on to the next person. I would thank you all. You're all on my speed dial and have been for many years, and I can't thank you enough for all of your input and your help. And we appreciate all the information today, so thank you very much.
You're welcome.